Good morning and welcome to Structural Heart Live Cases from the Mount Sinai Hospital in New York City. I'm your moderator, Matthew Williams from NYU Langone, also in New York City. The case from today will be available later this week on the website, and the previous case from October is available in the archives now. We'd love to hear any questions or comments you have during the case today, and if so, please email us. You see the info on the website, but it's info@structuralheartlivecases.org. Well, we have a very exciting case today, and let's go ahead and get started. I'd like to turn it over to the team in the room. Dr. Sharma?
Good morning, Matt. And we have let's put everybody on the camera so that everyone comes on the screen here. Myself, Dr. Keeney, Dr. Stewart, and Jason Kovacic, and our fellow Mithun. So we all are ready for this case, and particularly the expanding, I would say, the indications of the TAVR getting to the higher annulus, because we learned that now getting to the intermediate and going from extreme to high risk to intermediate, the most exclusion is because of the higher or larger annular size. So we actually will have a case here which we are going to demonstrate, which we're using a 34 millimeter EVOLUT R, which can go up to a 30 millimeter annular size. With that note, with our team, we quickly go through our slides, and they're ready for the case presentation. If we can get to the slides, please. So these are our supporters. Next. These are individual disclosures, basically nothing for the particular case today. Next. This is an 85-year-old patient who has presented with worsening dyspnea and fatigue for last few weeks, has known severe aortic stenosis or moderate to severe, now became severe, and sometimes with the patients, because patient also has the chronic pulmonary fibrosis and COPD, so very tough to differentiate, but echo showed a significant aortic gradient and severe AS in this particular patient. And EKG-wise, just a moderate CAD, which was FFR negative. And this actually question comes very often. And this weekend on Saturday, the issue was that a lot of audience asked us the question in Dr. Fuster's conference, CAD and TAVR. And clearly that we all know that if you have significant CAD, do it before. As such as last week, just the guidelines have come from the ACC that knowing that these patients don't fall into the appropriate criteria, you cannot do stress test, you cannot even do FFR on many of these cases because of adenosine causing bad reaction. So they are very clear, the change guidelines, which will be adopted, I hope, very soon, because just shown by the ACC, the website last week, that significant CAD should be taken care beforehand. Even there is a questionable, you do it before getting the TAVR, because after the TAVR, definitely the PCI is slightly difficult, particularly more so for the CoreValve. Next. So this is basically patient has CT, and we'll show that overall risk 5.6, and patient determined to be the high risk, and they're here for Medtronic EVOLUT R CoreValve 34 millimeter by percutaneous femoral access and conscious sedation. And of course, our anesthetist do a great job. About 65% cases are being done with a conscious sedation, and sometimes you start with a conscious sedation but convert into a intubation, largely because the patient is very unstable or cannot lie flat and so. But majority of the time, when they decide about the conscious sedation, case is done with that, and of course everybody wants that way. Next. Now echo, now I'll hand over to Partho on this echo issue. Clearly patient has high gradient, and we can have a live echo shown now.
So back here we have our team, Dr. Khan, Dr. Agrawal, Dr. Liu, and the anesthesia and the collaboration has been great. This patient is undergoing a conscious sedation, so it's a moderate to a deep sedation, and this is a TEE. This is actually a pediatric TEE probe, which is being used, and the patient is tolerating the probe very well. And the reason this is important is you will see this patient has severe aortic stenosis, but when you see on TEE, this is the short axis view for this patient, and you will see that there is a very unique geometry that the patient has. This is the left coronary sinus, this is the non-coronary sinus, and there is a calcified fusion you can see of the commissure here between these two sinuses. There's a very large right coronary sinus, much larger than the other two, and the orifice is very eccentric on this side. So this is looks like a functionally bicuspid aortic valve. The patient also has some underlying collagen vascular disorder. So there's a fusion of the left and the non-coronary cusp. Then you can see subsequently that the patient has a clearly severe aortic stenosis, mild restriction. There's a lot of calcification you can see of the aortomitral region. Particularly if you zoom out, you start seeing there is a lot of calcification of the aortomitral region curtain here. And there is also annular calcification around the mitral. And this is important because this can pose some challenges with expansion and can cause paravalvular regurgitation. So we'll be mindful of this anatomical details here. Another issue in this patient is that there is a sigmoid septum with a basal hypertrophy which encroaches into the LV outflow. You can see much better on the still frame here. This is the aortic valve, this is the mitral valve, and this is this bulge of the sigmoid septum, which is coming about 30% into LV outflow region, not causing any LV outflow obstruction or gradient. But again, mindful of this anatomy is useful because you have to be cognizant with the placement and the challenges that sometimes can be imposed because of that. Again, a measurement of the basal septal, it's about 1.9 centimeters, so it's not insignificant. There is a septal hypertrophy. And then in addition to that, the patient has a mitral inflow, mild inflow obstruction with moderate regurgitation. And this is the zoomed out view. You can see the aortic valve stenosis. There's no outflow gradient, mild aortic regurgitation, moderate mitral regurgitation, and some inflow gradient, which is about 4 millimeter mercury mean. So with these details, I will turn over to Dr. Sharma because these details sometimes can be useful on the strategizing on how to approach the next steps during the TAVR.
Absolutely. We can go back to the slides, and clearly very important, particularly when you're deploying the valve and with the septal bulge. Next. JK, take over for the CT.
Sure. Good morning, everybody. So the CT measurements here, it's interesting. Oftentimes with this functional bicuspid anatomy that we've found this morning on the transesophageal, often we get a good sense of that with the CT scan. Really saying even with hindsight, we didn't have an appreciation of that on the CT. It really wasn't evident that we had a functional bicuspid anatomy. Go back. No, back to. Stick on that. Go back. So here you can see the annular measurements. We're getting measurements around a mean of 38. There is a piece of calcium in the sinus. You can see there the coronary heights are fine. The right's about 20, the left is about 17. Generous and accommodating measurements. Next slide. We're missing a slide here, but the annulus, when we measured it.
Go back to the earlier slide. Earlier.
Yeah.
Yes.
Good here. Good.
Yep,
you can see here the annular perimeter. Here it's 89. We got anything from 86 up to 89. There is a piece of calcium was evident that Dr. Sengupta was just showing us. It does extend down into the LVOT and into the mitral aortomitral curtain. The perimeter is 89, which is clearly in the range of the 34 valve. And really the annulus, the angle of the annulus is fairly reasonable for today's case. So next slide. Next, we've done that. So here you can see the access. We're going up the left side today, fairly straight, a little bit of patchy calcification, but fairly generous vessels, around 8 to 10 millimeters here for the access. Next slide. And here you can see that bilateral hip prosthesis, so there's a lot of artifact on the CT, but you can see it's about 10 millimeters in diameter for the left and right access points.
Okay.
Next.
Next. Yeah, so this is now the valve size. Anu, you want to comment on this case?
Yeah, the new valve that just came, I think, few months ago with regards to the EVOLUT, what we call is 34, equivalent to about 31 that we used to use the core valve. What has happened, if you see the height of the valve has decreased, and essentially what you see, the width, how it gradually widens to get us a bigger annulus, and that is where you have to see, I think, how you can go up to 34 if you see a perimeter, up to 94, and I think our patient is just about 89 or so, and then the sinus of Valsalva height has to be more than 16, and ours is about 20. That's, you can see this patient ideally fits in. Show the next slide where we can see how this valve.
Next.
This is a EVOLUT 30 What happened to the comparison?
Next.
Keep next. The delivery system actually has the increase in the size to about 16 French now. So you got to have a vessel size greater than 5.5. So our patient fits into that particular size.
So this is definitely 2 French higher than your regular EVOLUT of your 23, 26 and 29.
Which is a 14 French.
Yeah. Next.
This is, I think, comparison where you see your old 31 core valve and your EVOLUT 34. The height definitely has decreased, and you see the width at the bottom has become up to 34 or so. So much so that they say the valve area, the virtual valve area that you get after you place this valve could be up to 2.5 centimeters squared.
Yeah, next. I mean, that called less regurgitation. Next. And this is our same 5 millimeter. Next slide. I think this is the important one.
If you go back to the slide, so you can show the diamonds. See that diamond, the entire one diamond is about 6 millimeter or so. So the goal is about half a diamond, which is about 4 millimeter. That is where I think our aim should be when we are placing the valve, that at the annular plane, so 4 millimeter just below the annular plane, to place this valve. Go next. This is what they've shown, that whatever few cases that have been placed, that they're saying the valve area that they're getting is close to 2.5, near normal.
Yeah, now Partho, is that been your experience with the our EVOLUT 34? We have done what, 6 or 7 cases that the valve area comes almost +2.
I think the number of cases I've not systematically looked into our reports, but I think in general the impression is the same.
Yeah, and that's a very interesting. And now I'll ask Alan to say that effective aortic orifice, not the valve size. Many times I'm sure you deployed 25, 27, 29 millimeter surgical valve, but having a effective orifice of 2.5, which is approaching near normal.
It's not seen in surgery.
Yeah,
no.
it's never
no matter
seen
how
here.
size how big of a valve we put.
Okay, next. So therefore we put together, this is the case for high risk and appropriate. Now while we are trying to get the case, we can go back on floor and I'll ask a very pertinent question, and that question actually again, this Saturday when we have this tower symposium as a part of Dr. Fuster's meeting with the 2200 plus cardiologists, physicians and so. The question basically was also that while it was good, everybody adopted the high risk and intermediate risk by the community, by the physicians and by patients, that getting in the low risk, everybody having a quite difficulty in convincing our patients, our physicians, cardiologists and so, that it's okay to get into the trial. What is your take on it? Because people still not convinced that if you are putting this core valve or a sapien valve in the age of 62 is the right approach rather than putting a surgical bioprosthetic valve.
It was easy for us to adopt a patient like this. He's 90 years old. He's got COPD. He's on oxygen. No one would have a quarrel with this patient having a TAVR. In fact, before TAVR, we would operate on this patient with the expectation that he was never going to go back to his own zip code, or would be either living with family or in an assisted living after surgery. So we wouldn't really feel good about that. When we start to get into the folks that are 65 and have the expectation that they're going to outlive the CoreValve or outlive the sapien, it becomes a question of, well, what's their next procedure? Is their next procedure a valve-in-valve TAVR, or is their next procedure going to be an AVR? Now, an AVR after TAVR is not equivalent to a native valve AVR. The fear is that taking this out after it's been in half a dozen years or a decade is quite an operation or quite a procedure, and I think that's the fear, as real or unfounded as it may be. So I think when we start getting into low-risk patients where AVR is still a procedure that can be performed with a 1% stroke or 1% mortality, it becomes a different question.
Yes.
But time will tell.
Yep. I think that's a very important. Matt, you can comment on also on your side, because I can tell you personally here, you need a pigtail to adjust, or we are okay?
I think we are.
The wire is in good position, Partho?
Yes.
Good. And do the valvuloplasty. Huh? It's not good? Okay. So we crossed with the AR2 as you saw, and now we are going to reposition by putting a pigtail so that the wire has a good curve at the apex.
Now, what will be your strategy here? Are you going to, are we going to assume that echo is correct and that this is a bicuspid valve? I mean, I'm sure Alan can comment on this, but the asymmetry of the sinuses is certainly very suggestive of this being a bicuspid valve. And, is this a case that you're planning on pre-dilating?
Yeah, definitely we'll do a balloon dilatation, and question is that even if it's acquired bicuspid, once we dilate and put a valve, hopefully that part is taken care. In the all low risk trial, as you know, the bicuspid is excluded, the part of the registry only, and this particular case actually is truly a high risk patient, so that less of a surgical option.
Sure, and I think as a general rule, all bicuspid valves, at least for self-expanding, probably should be dilated. I tend not to pre-dilate pretty much any of my cases unless they're very high velocity, with the exception of bicuspid.
So should we go without a pre-dilatation in this case?
No, I think
I
personally think you should.
Yeah, because the bicuspid we have to, right?
Yeah, yes, I think it's
So I
strongly
think
encouraged.
I think there's a positioning challenge. I think the pigtail is getting caught in the subvalvular apparatus, and
We are out now.
Yeah, now it should be better.
It's still, yes, now you're out, but again, it is still getting caught in the subvalvular apparatus. It's right now submitral and.
And what wire are you using?
This is just a regular wire too.
Earlier we had the implant super stiff, right?
Okay.
Yeah, but this one is just to manipulate and get the our pigtail to the apex, so make a nice curve. I thought the earlier was reasonable position. Yeah, good. What do you think now?
No, I think it is reaching. Yeah, but my concern is that the pigtail is caught up in the subcaudal subvalvular apparatus. So I think you'll have to
come back and try
yes,
to.
and you leave the wire back and pull back the pigtail and then try to.
It's going to come out now. Good.
One of the nice things about this valve, I mean, you were showing the design earlier, but as you know, with the prior system, with the 31, it had this very steep shoulders, and so it tended to dive quite a bit, and that was one of the issues with the 31, and this is the design, the stent
Now it's
frame.
better, no?
That looks better.
Yes, you are at
Yeah,
the
the
apex.
design wise, and
Perfect.
particularly the design is so that it causes less paravalvular leak. Now, only question.
Less powerful, and it also doesn't dive because
Ah.
it doesn't have this steep slope on the shoulders, which tended to, almost watermelon seed it to some degree. So you don't have the same kind of diving that you did with the 31. Plus, it's obviously recapturable, so you can adjust for it if necessary.
Now, what is your experience about the requirement of pacemaker with the 34 versus regular our 31 millimeter core valve? Because I don't know much data because they only published data of the 15 patients so far, which led to the FDA approval of the device.
Yeah, I know. It's. I don't think we know. I mean, my anecdotal experience has been we were, in the trial for the 34, but it doesn't seem to be better or worse, but it's such a small number of patients at this point that I think it's tough. But but to your point, I mean, it really shows how the FDA has changed, that it was a small number of patients required, but we're also the only country in the world now that's using this valve, and 5 years ago that was unheard of, right? When we had our first transcatheter valve approved in this country, we were the 44th country in the world to have it approved, and now we have devices that nobody else in the world has.
Okay, pace at 120.
So this is a 22 millimeters ZMAT. One of you have to hold the wire.
Okay, stop pacing.
Good. So far, okay?
And will you use the inline sheath with the
I think
the system?
So, yeah, that's what we are going to do. 1 second. 1 second.
Okay, 1 second.
No, we are having trouble here.
No, we'll be okay. Good.
No, it's not coming out.
No, it will come out now. I'm negative.
No, it just did the same
Yeah,
yesterday.
It will come out. Negative.
Pull harder.
Okay. All right. So now ready with it's a 16 French sheath. So we have to change out now. So this is one of the things which I have been talking to the Medtronic people, is the simplest thing. This inline sheath 14, 16, they should be able to disconnect. So that whatever you need to do, particularly with the 14 French, we know that you have done pre-dilatation. You don't want to do anything post, and you can directly go. But that's, I think, will take another few months. Because this exchange is the one always creates a problem.
Sure.
So can I just show the
Yes.
echo
Sure.
quickly? So after the balloon dilatation, the calcified raphe fractured. So I think this is a functionally bicuspid, not a congenital, because you can see there is a fracture of that raphe area,
Go straight.
and there is moderate aortic regurgitation.
People would argue with you whether there's any such thing as an acquired bicuspid other than perhaps the inflammatory process like rheumatic, but I think they're,
I would agree, Matt.
yeah, I think it's, we call it functional because there's 3 cusps, but it, you know, but which is the mid, you know, the mid, you know, as Alan can comment, what it's maybe 5% of bicuspids are actually true bicuspid valves.
Yeah,
Right?
most have a joined raphe, and the raphe is present since birth. It's just dependent upon how much calcification
Some
there
dye
is.
here?
But I don't think there's any such thing as acquired.
Good.
Yeah, I think maybe some rheumatic or radiation
Okay.
kind.
Okay. Go to the view. One second.
This patient had probably some spondyloarthropathies and collagen vascular disorder.
Well, he does have a bit of an aortopathy as well.
JK, we are okay? Okay, we go. Wait. We're going. Sinai. Inject.
Good.
Okay.
You know, and there's also an argument that with bicuspids you can place it a little higher because the seal tends to be more on the leaflets and higher up.
Okay, start pacing. 150.
150 or
A little
150?
high.
Okay.
Yeah,
You gonna turn this thing? Said?
did. That's good.
Inject.
A little high.
No.
Yeah, we are high.
Hold it.
Come on.
Okay,
Keep
stop
going.
pacing. I think we have to go in.
You can
Other
stop.
side we are not reaching, right?
Yeah. You want to take a
Okay.
picture or no?
No, stop.
All right, I'm
Stop
in the rumble
pacing.
strip. I think you're okay. actually.
No. Inject. No. I think
What
we have
is
0 and
to
2.
Okay, touch high.
What is
recap.
that?
I think we
Equity.
recapture again.
Huh?
It's not on the left side. Pace.
Okay.
It'll jump otherwise.
Yep.
Okay, stop pacing.
Okay. Make it a
Okay.
little-
You stop
Yeah.
pacing. Good. Give a little gap. Little recovery. I think go one last.
Two things that we have noticed that with the 34. One, we have to pace as we are releasing way early, pacing. Another thing also, you counter clock. So, which we already did. You see that it is already coming to one side of the wall. Otherwise, this also dives a lot.
We need a blood pressure to come up a little bit.
So
Blood pressure?
Just to flow it.
probably related to severe AI.
Okay.
And the
You want to push a little bit more, or we are
I
okay?
did.
these
Some dying.
bicuspids tend to have more
Little die only,
horizontal
not thinning.
aorta as well.
Yeah.
Good.
Okay.
Everybody good?
Yeah.
We try
Okay.
again. Okay.
Pace. It's better.
Nice. It releases there.
It's too high.
No, we're good.
Yeah?
I think we're okay now. Okay,
Okay,
stop
we're good.
pacing. Yeah. You want to take a cine? So we see where we are. Inject.
Good.
Okay, now we are
Looks
better.
good. Okay.
Partho,
Yes.
we're going to release, okay?
Okay.
Go back.
Yeah.
Off.
Separate.
Okay, good.
Yep.
Separated. Careful now. Assess.
No,
Advance the wire. Pull now.
yeah.
Good. Okay. Okay. Just sitting there.
It's like a 0.
I know.
Yeah.
Is that not too low?
What do we do?
Nothing. It looks okay.
Huh?
We don't see any leak.
Oh, it's a little.
Partho?
It looks
Yes.
like
So
wire related.
we are just now. What's the blood pressure?
If it looks good, leave it.
It's like wire related. no?
Okay. There's.
Yep.
Okay.
Go other
What?
side. We are going to press it.
What'd you say, Partha?
So there is more transvalvular aortic
Yeah.
regurgitation. And I'm just trying to see if there is a, at the 12 o'clock position, you see that there is also
if
an
you don't
area
need it, you're done.
paravalvular.
Don't
Small
post if you
though.
don't need it.
The only thing is that the valve is at a zero position. I mean,
Yeah.
on one side is at a zero position, just at the annulus.
Okay, let's get this one first.
Let's do a AO then.
There is a lot of transvalvular AI right now. The
Center
wire
the valve.
related.
Good, good. Okay.
Okay, ready?
That looks better. Mhm.
Yeah.
Inject. Looks very good for 31. Oh, or 34.
34. 34.
Now, look
What
at
do you
the.
think?
Mag up
Leave
the,
it, leave it. It's coming out.
Looks
already.
very good.
Make the
The very little regurgitation. Only thing is we cannot post dilate, but you don't need to post dilate here anyway, right?
Yeah, get us a pigtail. Will come out, right?
yeah, looks
I'm
good.
I'm happy, Dr. Sharma, because
Yeah.
the valve is at a zero position. I wouldn't dilate it, risking any movement, because there's also basal subtle hypertrophy. And I'm not seeing any major paravalvular leakage. There is like a small jet on 12 o'clock position, 1 o'clock position,
Okay.
but otherwise it looks good.
And the diastolic pressure is 80.
Yeah.
Yeah, and I think with that calcium, you're
Yes.
you're not going to get a perfect.
looks very
seal. I
good.
think
You
it
don't
looks-
need to
looks
post.
fantastic.
And that's expected. A little bit of paravalvular is expected.
You don't need to go in, right? Okay.
Okay. So now with that note, while echo and clearly we go back to our our slide presentation. The procedure wise next. So we always talk one point, and that is latest data have come up of the outcomes of the valve-in-valve tower or VIV. Next. And basically we know the first report actually was in 2011 when they used the Edward Sapien for bioprosthetic restenosis, and since then, next, lot of data have come about using the tower for the bioprosthetic aortic failure. Now, a few things which has clearly come, that compared to the native tower, lower risk in the valve-in-valve is that there is significant paravalvular leak. So while in the native tower, you actually have some paravalvular leak because of the nice fit, you have a less paravalvular leak, less tamponade, less annular rupture, dissection or conduction defect. But there is higher risk than the native tower in terms of device malposition, which I am not sure, because most of the other data showed that device, you have very nice good position where your the tower valve has to sit in relation to the original surgical valve. Yes, there is higher ostial coronary occlusion and elevated post-procedure gradient. While you bring the gradient to about in single digits, about 5, 6, it's not uncommon, leave 15 to 20 millimeter in teens, the gradient in the residual gradient post-tower in these valve-in-valve cases. Next. Now, first report, systematic report came from the again global valve-in-valve registry. Next. And basically showed that, as you can see here, that early results, the overall 30-day outcome reasonable compared to what we have in these elderly patients, but there was slight difference in terms of what we learned after using them, the mean gradient. The mean gradient with a core valve, because of its position of supraannular, that it's lower mean gradient with a core valve versus Edward Sapien, which resulted in a better valve orifice. But yes, you did have a higher aortic regurgitation, which we always know has the core valve compared to Sapien. Next. Now these are the various data at various time points, which I've shown in the previous slide. Next. And it's also dependent what size is the valve, original valve was. So clearly that you are smaller the valve, you will have a higher residual gradient between two of these devices. Next. Now then there was another systemic from the same group on further large number of patients of the failed bioprosthetic surgical valve published in JAMA last year. Next. And it basically showed that, if you can see next, that overall that the 30-day outcomes was kind of similar between two groups of the valve, of the core valve, which is the self-expanding or the balloon expandable. But more importantly, that what was the region when the valve was placed, whether it was a stenotic degeneration of the bioprosthetic or regurgitation or combined. Clearly the data showed that you have better outcome with the regurgitation if your degeneration of the bioprosthetic aortic valve is predominant regurgitation compared to stenosis. And this is basically goes down to the residual gradient. And then they also compared whether self-expandable versus balloon expandable. Next. And you can see here overall higher need for permanent pacemaker with a self-expandable. Next. But advantage is that you have larger valve area. Next. And you have a lower mean gradient as I discussed earlier with the self-expanding, which is core valve compared to balloon expandable. So clearly these are some subtle differences, but they sometimes can make a difference in overall long-term outcome of these patients. Next. And this is actually at 1 year, as you can see. Next slide. That basically the gradient persists, and overall the death, stroke and so were not different. But key is that still that the self-expanding gives you better valve and better hemodynamics compared to the balloon expandable in this situation. Next. And this just to highlight that if you have stenosis as a type of valve failure, outcomes are worse compared to if it is regurgitation. Next. And that balloon expandable is self-expanding, and initial size of the valve is also very important, particularly what gradient you leave, if it was a large valve versus small, and because of that will create the patient prosthesis mismatch. Next. Now this is another kind of a in vitro study to just show that orifice area and the hemodynamics definitely you get better with the balloon expandable, I mean with the self-expanding rather than balloon expandable, but you definitely have a little higher regurgitation. Next. Now this is the data from the CoreValve US for the valve-in-valve trial of 107 patients. As you can see, overall 1 year outcome, I would say even better than what we had for the native aortic valve, and definitely better will be better than the surgical bioprosthetic if you do a redo surgery, about 15% event rate and of the death and stroke. Next. And one of the important issue was that what caused this hemodynamics means we know you cannot get a valve area of 1.7 or effective orifice of 1.6, 1.7. Usually you can get 1.3 or 1.4 and residual gradient of 16. Next. What drives this? The basically impact of this higher gradient. Next. And it's very important that cutoff is 20. That if your residual is less than 20 or more than 20, it has a differential outcome. So goal should be to bring it down to less than 20 post valve-in-valve. Next. Now what causes it? What is driving this higher gradient? One is the surgical valve size. If your original valve is small, you will always will have some gradient. Secondly, modality of failure. We saw that if you have stenosis, you leave a more residual gradient. And lastly is the patient prosthesis mismatch. So clearly you should try to overshoot, in this case oversize it rather than undersize when you're using the valve-in-valve for the bioprosthetic valve failure. Next. So therefore, if we sum up with the take-home message is the TAVR for failed surgical aortic bioprosthetic valve is feasible and is associated with acceptable death and stroke rates and 1 to 2 years of follow-up. Hence, valve-in-valve TAVR is an acceptable or recommended option in appropriate AS patients, because key is still that even in this group of patients, just like a native aortic stenosis, you have to go through the same surgical risk, STS, because only the patients with the high risk and intermediate risk are appropriate for valve-in-valve. It's not that every patient is should get it, but I personally feel that hopefully with the updated guideline and knowing the data are so good, that why would you do a re-op surgery, and these patients should be preferred, whether it will be a class 1 indication in the updated guideline we need to see. Second is that valve-in-valve TAVR outcomes are strongly associated with residual aortic gradient, post-procedure and the mechanism of valve failure. And that's where we learn about that if it's stenosis or a small original valve, they have a bad outcome because they have higher residual gradient, and every effort should be made to decrease the residual aortic gradient to less than 20 millimeter of mercury. So, Anu, you want to make any point on the valve-in-valve? Then we'll go to the questions.
I think even with our experience, I think what we have seen is, though initially, conceptually we felt that balloon expandable valve probably is better in valve-in-valve compared to self-expanding, but we've seen the self-expanding valve definitely gives lower gradient compared to the balloon expandable valve. we still don't know that in certain cases there are in smaller valve that you have to consider expanding the valve the bioprosthetic valve before we place the new valve.
Now, Matt, from your point of view, if you have a choice, the patients with the bioprosthetic failure, aortic failure, what will be your criteria? Try to push for the TAVR versus redo surgery.
Yeah, I've become very aggressive about valve-in-valve with the TAVR. I think if someone doesn't have prior bypass operation, the surgery is relatively straightforward, but I think the recovery is obviously so much better. Provided they have an appropriate size bioprosthesis, which of note is important for us as surgeons to take into account with this as a future strategy. So if we think that our goal is to put a tissue valve in a younger patient, that in the future we'll have a TAVR valve-in-valve, that we're going to want to make sure that we put a large enough valve in, even if it requires a root enlargement. So, provided they have an adequate size valve, which certainly depends on the size of the patients, I will predominantly proceed with the TAVR valve-in-valve for all of these patients. And my guidelines are if they have a 23 or smaller, I will always use a self-expanding system. If it's larger, then I think either one is fine at that point.
Because clearly, as you pointing out, that you need an oversize. Now, second question, many of this our limitation of these bioprosthetic for the TAVR is that the original aortic valve is less than 19 millimeter. Now, what is your take on now some 5-6 cases presented by Cedars-Sinai group, Makkar and I think Chaturvedi and so, showing that some of the old surgical bioprosthetic valves with the special indiflator, you can break it if it is a small, and then after implanting the TAVR, that you can go and break that geometry of the old surgical valve. You believe it in it, or have you some experience on that?
No, I mean, we've tried to blow some of these out, and it's hard, and the balloon tends to watermelon seed and migrate the valve. I also think the incremental gain is not that much because you still have a lot of fibrous tissue around the valve, and the fact is that the native annulus is obviously small to begin with, or that size valve would not have been placed. If someone does have a 19 valve and they're operative, then that's a patient I will push for surgery even if they're high risk. If they're not operative, a lot of these patients will have a velocity of 6, and so while you may leave them with a suboptimal gradient, it's probably still better than what they're dealing with now. And if they're truly non-operative, I think it's an appropriate procedure to do in the patient, because you're going to improve them. You're not going to get quite the results you want, but you're going to put them in a much better place than they would have been otherwise.
Beautiful. Now we can go to the questions while we are finishing this the vascular access. There are 3 questions, as we always do. Following the false statement regarding TAVR procedure in aortic bioprosthetic failure versus native aortic valve TAVR, that is the higher residual aortic gradient, lower annulus rupture, lower coronary obstruction, and less paravalvular regurgitation. As we know, next, that there is a higher coronary obstruction for the valve-in-valve, because that is one of the predisposing factor besides the height of the coronary ostia. Next, second question. Following statements are true about the outcome of balloon expandable versus self-expanding TAVR valve, except lower need for permanent pacemaker, lower residual aortic gradient, lower paravalvular regurgitation, and similar long-term death and stroke at follow-up. So clearly, as we discussed here, the lower residual aortic gradient. Next, that clearly in the self-expanding, you have a lower compared to balloon expandable. So that's a false statement, that balloon expandable will not have a lower residual aortic gradient, rather will have higher. Next, the third question is the following are the usual factors responsible for higher residual aortic gradient post-core valve-in-valve TAVR from the registry, except one is the modality of bioprosthetic valve failure, baseline surgical valve size, predicted patient prosthetic mismatch, and need for permanent pacemaker. Next, and clearly, as we discussed, that is nothing to related with the permanent pacemaker. Other 3 factors are very important in terms of what is causing in these cases the higher residual gradient. So before we conclude, you want to just say a few things, vascular, we can show back to the angiogram with Jason.
We just go back to the angiograms, please. So that was our last shot of the valve deployment. So what we've done now is before we got started with the case, we placed V18 wire and 018 wire from the right femoral across into the left femoral system, and then we put our perc closers in, and then we took the access. So what you're seeing here is we've taken a long sheath, 40 centimeter sheath, up on that 18 wire, 018 wire, up to the aortic bifurcation. We're just doing an initial DSA shot to make sure there's no trouble. We've retracted the CoreValve system, the EVOLUT, back into the external iliac there. And you can see there was some calcium. It wasn't a clean vessel, so we're just checking on DSA. There's no problems, no perforation. Looks good. So the next shot we've done is we've now taken the valve out. We've deployed the 2 pre-closed sutures, and we're just taking a look at our initial shot. You can see there already we've got fairly good closure. We've still got both the retrograde and the antegrade wires down in case we had trouble. I always like to come with the balloon because on the rare occasions we can snag that 018 wire under the per-closed sutures, and by running the balloon down we can ensure ourselves that we haven't snagged that wire and we don't cinch the wire up with the per-closer. So although there wasn't much of a problem there, we still most times will inflate this balloon to very low pressure. It's a 7040 balloon, just to 4 atmospheres. Cinch down the per-closed sutures on that, and here's our final shot. It looks pretty good to me. So that's the conclusion of the access. Looks nice and clean.
Well, I have
no
seen that
leak.
with this your balloon dilatation, you actually that small indent you always see with the perclose kind of disappears.
Yes. I think it's so benign. It was so efficient, and I'm sure everybody here is Matt as well, that it's so efficient in putting that wire across. It gives us great reassurance. Although the sheath sizes have come down, I think we're in the habit of it, and it's a very good practice.
Now, Matt, are you using this routinely 018 wire other side, contralateral side?
Yeah, I think it's a great technique. It's like JK said, it provides safety. I mean, I think it saves a lot of time in the room, because even after you close, if you have a little bit of ooze, that you put the balloon up for a minute or 2 rather than hold pressure for 15 minutes, you get a completion angiogram. I think it's a safer procedure. It's just hard to predict some of these vascular complications, and it just makes it so safe to do it this way.
Okay, well, from our side, we have completed this procedure for today, and then you just make your closing remarks, and we are all done here.
Thank you, guys.
Great, that was a fantastic case. I'd like to congratulate the whole team. You really demonstrated what this valve can do, and I'm sure the patient will do fantastic. So thank you for joining us for the last Structural Heart Live case of 2016. This will be in the archive in the next couple days on the website. And I would like to tell you that the next Structural Heart Live case will be on Tuesday, January 10th. Thank you very much for joining us.